Good afternoon, everyone. John Snyder here with another edition of Newton-Wellesley Medical Group Lunch and Learn on this gray Thursday afternoon. We are really excited to welcome Petya Papazova over to our hot seat to talk to us about leg pain. And Petya, if you can advance to the next slide. Thank you. We want to tease some upcoming events. Remember, next week is school vacation week. We will not be here, but a good time to catch up on one of the lectures that you have missed. They're all archived up on our intranet as well as publicly on YouTube. So if you're on the beach in Miami or somewhere else and you want to catch a couple of great lectures, go ahead to YouTube and search Newton-Wellesley Medical Group Lunch and Learn, and you'll be able to see all our offerings that you'll be able to check out 25-minute intervals. Next slide. Newton-Wellesley Hospital also wants to remind folks that we are celebrating Patient Experience Week the following week after school vacation, April 25th to 29th. There'll be special messages of thanks and chicken noodle soup for all our inpatients, celebrity slideshow on Newton as well as social media recognition. So please remember to thank your patients for choosing Newton-Wellesley Hospital for their care. And this is a nice, one of the recipe cards that we will see on home-style chicken noodle soup. Next slide. I want to remind folks, because this benefit is, we have paid for this for a whole nother year, our physician care concierge service, not just for physicians, all APPs also through November of this year. Please sign up for this. It's free, and it is a nice way of obtaining services that you don't have to go digging to see who the best person is to mow your lawn or to plow your driveway or to get your lawn ready for springtime or chop your trees down or I don't know, find a moving van or anything like that. Best present for Mother's Day or Father's Day. They will do all the research for you, free, and it's very non-intrusive. You send them an email, what you'd like. This is free. You can just go to community.circles.com. Please make sure you get that URL right, because if you Google it, you'll have the wrong URL. Register with the welcome code NWH, and you'll be good for a whole year. A reminder also, it comes with +1 access to a spouse, partner, relative, or friend. Next slide. And then our Pay It Forward program is still going strong. We do have $100 gift cards we'd like to give out to providers that have helped you. The way this works is a provider has helped you help with care for a patient, and you want to say thank you, besides saying the courteous thank you and couldn't do this without you. You can also send a note to Kathy Servan. I recently did this to one of my colleagues who helped me with a very difficult patient, and the gratitude that comes back is really nice. And then what would happen is that physician would then keep the chain going and pay it forward to another physician or provider. So please keep that going. This is part of our program, and it is funded by the Joy of Medicine grant. And, you know, this is one of those, while supplies last, let's use up the gift cards and the money. Next slide. And I'll turn it over to Petya. Thank you. Don't forget to unmute yourself. There you go.
Great, thanks, John. Good afternoon, everyone. My name is Petya. I'm a nurse practitioner at Newton-Wellesley Hospital for the vascular surgery services. I work with Dr. Mohapatra. We're located at the Alfors Cardiovascular Center 2 West, and we offer a full spectrum of vascular care, arterial and venous diseases, open surgical and endovascular treatments, medical management and surveillance. We offer in-office and same-day vascular lab testing. We work in collaboration with Mass General Hospital. We specialize in arterial and venous diseases, including aneurysms, carotid artery stenosis, peripheral arterial diseases, varicose veins, leg swelling, and venous ulceration. We're going to talk today about leg pain, vascular aspect of the leg pain. There are multiple there are many reasons for leg pain. The leg pain can be very multifactorial and very complex, starting from the musculoskeletal, to nerve, to neuropathic, to skin, arteries, and venous diseases. In this talk, we'll focus on vascular conditions related to leg pain that brings patients to our office. And I'll start with the peripheral arterial diseases. Taking detailed history and examination is essential in diagnosing peripheral arterial diseases. Usually, a typical patient has diminished lower extremity pulses or absent. If a patient comes with leg pain and bounding pulses, usually this is not a peripheral arterial diseases. Impaired, usually patients have difficulty walking, intermittent claudication, ischemic rest pain. More advanced signs would be gangrene, lower extremity non-healing ulcers, power and elevation, and independent vulvar. Usually vascular bruit is not considered for lower extremity, for peripheral arterial disease. Those are usually for carotid artery stenosis. Most of the patients, up to 75%, with peripheral arterial diseases are asymptomatic. Clinical manifestations, the three classic signs are claudication, rest pain, and tissue loss. Claudication is one of the first signs. It's usually cramping in the calves after walking short distance. It's relieved by rest and recurs again by resuming activities. It's usually the same distance. The cramping or the pain could be also in the thighs or the buttocks. Breast pain is a constant burning pain in the lower legs, feet, or toes. The pain usually occurs at rest, especially at night when the legs are elevated. It's usually relieved by dangling legs. Tissue loss, those are the non-healing ulcers and gangrene. When purely arterial, this arises, the ulcers arise at the tip of the toes. The peripheral arterial disease can also complicate neuropathic pressure or venous wound healing. Those slides are just an example of dependent vulvar. On slide A and B, this is actually the same patient with significant pallor when elevated and dependent vulvar when lowered to the ground, and thromboembolism when the clot is being shared to the leg. How do we test peripheral arterial disease? The most common and important tool is the ABIs, BVRs, and toe pressure. This is also the most appropriate test for screening. Often patients come with previously ordered duplex or CTA with Venous or MRAs. Those are more detailed studies that we plan when planning revascularization. We recommend that we stick with the ABIs, BVRs, and the toe pressure when in doubt whether this is peripheral arterial disease or not. When we order the test at Newton-Wellesley Hospital, we should search for lower extremity physio, rest and exercise. It's always bilateral. We do the physiological arterial testing at our vascular lab. We take the segmental pressure, record the branchial, and multiple levels of lower extremity, bilateral, and we also PVRs at multiple levels. How do we calculate the ABIs? This is the ratio between the higher of the DPs and PTs and the higher of the brachial systolic blood pressure. Sometimes those could be falsely elevated or incalculable if the vessels are calcified or not compressible. This slide demonstrates a pulse volume recording. You can see that on the right lower extremity, we have waveforms that are blunted with reduced amplitude compared to the left. What is the criteria for lower extremity peripheral arterial disease when diagnosing those? Usually the desirable level would be 0.9 to 1.3. And moderate to severe when it's below 0.7. We use the toe brachial index when ankle brachial index is not compressible. Those are the recommendations of the American Heart Association, 2016 American Heart Association and American College of Cardiology for diagnosing peripheral arterial disease. If the patient is at increased risk for PAD, we should diligently assess for collocation, rest pain, and non-healing wounds. If the patient has findings suggestive of peripheral arterial disease, then definitely we should do screening with ABIs. If the patient is younger and does not have symptoms, he should not be screened. The primary treatment strategies for lower extremity peripheral arterial disease include lifestyle modifications such as smoking cessation, also angiotensin converting enzyme exhibitors and angiotensin receptor blockers. And of course, statins and antiplatelet therapy. From the antiplatelet therapy, it's 81 milligram of aspirin, and the statins we recommend the high intensity statins such as rosuvastatin, 40 milligrams and 80 of atorvastatin. The recommendations for most patients with intermittent collocation would be a conservative approach, and surgical bypass, angiograms, and angioplasty would not be the first line of treatment. Before I move on to venous leg pain, I'd like to talk about scenarios of that are similar or close to collocation, true collocation. And this, the first that comes to mind is usually neurogenic collocation. Usually for neurogenic collocation, this is often attributed to spinal stenosis. The patients usually have discomfort starting proximally and progressing distally. Symptoms usually occur just by standing, such as waiting in a line, while for peripheral arterial disease or for collocation, the patients usually have cramping with ambulation. Symptoms usually improve by bending to open the canal or relieve the nerve root impingement leaning against, such as leaning against the wall or a shopping cart. Patients often say they could not sleep flat on their back, and they have to be in a fetal position or in the chair to improve the pain, for the pain to improve. And also orthopedic pain, it's often we have coexistence of peripheral arterial disease and arthritis. Often patients have localized swelling and pain. And ulcers. Often patients come to the office and it's hard to differentiate the ulcers between venous, arterial, or diabetic. Usually the venous, this slide will help to recognize the differences. Usually venous ulcers, they're shallow with flat margins. They have slough at the base, granulation tissue. They have the ulcers usually surrounded by hemosiderin staining, and they have normal capillary fills and pulses usually. Arterial ulcers, they are pinched out and deep. They have irregular shape, often covered by eschar, necrotic tissue. They usually have minimal exudates, and usually pulses are hard to find. Neuropathic diabetic ulcers, they're deep, surrounded by callus, and the pressure ulcers, they're usually at the point of pressure, and they're macerated. Moving on to the venous leg pain, usually the three typical reasons for leg pain are superficial tonsillitis, DVTs, and varicose veins, and the most prevalent is the varicose veins. About 23% of the adults in the United States have varicose veins. If we consider also spider telangiectasia, and reticular veins, the prevalence increases to about 80% for men and 85% to women. Risk factors. The most the most common risk factors are female gender, obesity, multiple pregnancies, and age. Clinical presentations, the initial symptoms usually are aching, throbbing, discomfort, usually localized to the areas of varicosities. More advanced signs would be hyperpigmentation, hemosiderin stain, edema, fatigue and heaviness, and ulceration. Imaging, we diagnose varicosities by venous ultrasound, venous reflux ultrasound, and the venous reflux is defined by retrograde greater than 0.5 seconds in duration. And how do we order those? We search for lower extremity venous reflux evaluation. Treatment options for varicose veins. Usually for all types of veins, we recommend lifestyle modifications such as weight loss, exercise, elevation, and avoiding prolonged standing. The most common compression therapy is 20 to 30. Usually 30 to 40 would be recommended for severe varicosities such as venous ulcers. Local ablative therapy, those would be sclerotherapies, cosmetic sclerotherapy, thermocoagulation for spider, telangiectasia, and reticular veins. Endovenous ablations include radiofrequency ablation and venous seals. And for larger branches, we would do stab and phlebectomy. Often we have patients coming to our office with bulging varicosities without pain. Usually we would recommend conservative approach for those patients. We would not consider surgical intervention. Most procedures have risks, and just having bulging varicosities does not put you at high risk for limb-threatening conditions or anything like that. Cosmetic sclerotherapy, we're happy to announce that we'll be offering cosmetic sclerotherapy for patients with reticular veins and spider veins. Those are low-risk procedure, and if any of your patients are interested, I would be happy to offer. And take-home points, when to refer. Please refer if the patient has lifestyle limiting collocation or for rest pain or tissue loss. We recommend to optimize medications only for asymptomatic patients or mild collocation symptoms. If you're not sure if this is peripheral arterial disease, then you should definitely check physiologic studies. Similar to varicose veins, please refer if the patient is symptomatic. Consider compression therapy, lifestyle modifications, and if we're not sure for whether this is leg pain caused by varicosities, please check venous reflux study. And this will be it. We're open for any questions.
So it's John Snyder again. So if there are any questions or cases, feel free to throw them in the chat. It looks like Dr. McNagny wants to know what's the exact epic order for the ABI. I think you did show that on an earlier slide. That's the one, because you want to make sure they do the exercise, right? That's the issue, I think.
Yes, we usually order, excuse me.
Yeah, I think it's in the front there. I thought I saw it.
Yeah, we usually order lower extremity arterial physio, rest, and exercise.
And you made a comment that always do the bilateral, even if it's only one-sided symptom,
yes,
correct?
That is correct, yes.
Okay.
Yeah, that's absolutely right. And just to echo that, if it's easiest if you always just order it bilateral and you always order it with exercise. Our techs are very good at using their judgment. If somebody's barely walking around with a cane, they're not going to make them exercise.
Okay.
But if you order it without exercise, it ends up being difficult after the fact to do an exercise study. So it's easier to just order the exercise study, and then we will often just forego the exercise portion of the study when they come to the vascular lab.
That's really helpful. Can you talk a little bit about either you, Abe, or Petya, about the antiplatelet therapy that you guys like to use? Of course, there's been a lot in there about primary prevention with baby aspirin for a 60-year-old or 60 or older. Do you go right to a full or a baby, and do you use anything like pentoxifylline, like we used to use Trental, et cetera?
Yeah, so typically really for these patients, most of them really just need a baby aspirin, 81 milligram aspirin a day. There has been, you're right, there's been a lot of both literature and lay press about primary prevention for aspirin. The patients that we see for PAD don't really fall into that category because they have clear evidence of atherosclerotic cardiovascular disease by the time they get to us, if they really do have PAD. So they fall into the same category as patients with known coronary artery disease, where they do benefit from a long-term cardiovascular risk standpoint to be on an antiplatelet and on a statin.
Yeah. And what about some of the other fancy antiplatelets like Trentals of the past or anything like that?
Yeah, so there's two medications that historically have been used for claudication symptoms that are not antiplatelets. The ones you're talking about are cilostazol or Platal and pentoxifylline or Trental. I will say I don't use them often, and I think Petya, we've talked about this as well, and they work in some patients, particularly cilostazol or Platal does work in some patients. I tend to use it more as a last ditch option in somebody who really does have symptoms that may warrant an intervention, but I want to avoid an intervention either because they've had several before and I'm worried about long-term durability of anything I do, or they're fairly young and we don't want to start this snowballing process early. And so often I'll use a trial of Platal to try to avoid doing an intervention. I don't really give it to most run-of-the-mill patients with claudication. It only seems to work sometimes. The side effect profile is not the most desirable. And so I use it fairly selectively. I don't really use pentoxifylline or Trental very much at all. And I think that medication in particular has fallen by the wayside. And so most people will just use Platal or cilostazol if they need something.
I'm going to keep going if nobody has any other questions. The other concern that happens a lot in the primary care office is we either make a diagnosis of coronary artery disease or cerebral vascular disease, or vice versa, we make an diagnosis of peripheral artery disease or a AAA that's growing. What is your sense, and I'll take it because you're a vascular surgeon, but what's your sense about hand screening these major arteries when one vessel is determined or one area is determined? And if so, should we be doing ABIs, or what would that look like for peripheral artery disease?
So in general, the guidelines say that you don't really need to screen anybody if they don't have any symptoms. Your common sense would tell you as it is that these atherosclerotic conditions all run in packs and people tend to have more than one. But when they do, if they're not having any symptoms, it tends to be, if it's asymptomatic PAD, for example, you're not going to manage it any differently, even if you know it exists. And so there's not really any literature or guidelines to support screening these patients, partly just because it doesn't change your management to know that they have asymptomatic PAD. Certainly history and physical exam are important, so getting a sense of whether they have PAD symptoms or if they've had a stroke or a TIA in the past, that's obviously important to know. Definitely not unreasonable to do a pulse exam or to listen for carotid bruits, but beyond that, actual screening, physiologic or imaging tests are not widely recommended for these patients.
Great. And then moving on to asymptomatic vascular venous disease, we certainly see many people, as you mentioned, up to 80% with large varicosities. Aside from the stockings, and if they don't want to do any cosmetic changes, is there anything you tell them about long plane rides, about perhaps skin care that can prevent venous ulcers or the vexing problem of the staining of their lower extremities that I frequently get complaints about?
Honestly, not really. If their varicose veins are asymptomatic, this is actually, Petya and I have talked about this. This is sort of the hardest patient population for us to treat because They're like these big bulging varicosities that nobody really wants to have or to see on their legs. But if they're not causing symptoms, none of the treatments that we have are really justified from a risk standpoint. And so we do tell these patients that they should try compression stocking. Sometimes patients have symptoms in their legs that in hindsight they had that compression stockings help with, but they just didn't know until they tried compression. So, you know, the occasional patient will say, yeah, I thought I was asymptomatic, but I started wearing the stockings and now I can walk further. My legs are less tired at the end of the day, so on and so forth. And so sometimes you'll see that when you ask patients to wear compression stockings. More often, they'll just say, yeah, the stockings are really uncomfortable. I don't like them. To which I respond, then you shouldn't wear them because this is really mainly a problem of symptoms. And if your symptoms are better not wearing stockings, you shouldn't wear the stockings. There's not really any increased risk of DVT with chronic venous insufficiency and superficial venous reflux. That being said, I personally just tell patients it's not a bad idea to wear compression stockings if they're on a long plane flight or a long car ride. It probably helps with their risk of superficial thrombophlebitis, which is not a dangerous problem, but it is an annoying one. And so it doesn't hurt to wear compression in those situations.
And then there's another question here about what are some of the risks that you tell people about with stripping of these veins?
Yeah, it's this is part of the reason why it's tough. When patients are having a lot of symptoms from it, the procedures that we have to treat these symptomatic varicosities are not high risk, but they're also not trivial risk. When we talk about stripping these veins, what we're really talking about is phlebectomy, which is making a number of small incisions up and down the varicosities and physically removing them. That's not a treatment that a patient's insurance is going to cover if they're asymptomatic, and it's not a treatment that patients or you or I can afford. So generally, it kind of is a non-option in these situations. We do sometimes sclerotherapy for the occasional asymptomatic problem. This is primarily something we do with spider veins, the little tiny ones, because we can inject a little tiny bit of sclerosant to treat them. These larger varicosities, typically to successfully treat them by sclerotherapy, we have to mix the sclerosant with air to make a larger volume foam so that we can actually coat the entire wall of these varicosities. That's, as you can imagine, because that's injecting air into veins, it's not always the safest thing to do. It's not terribly dangerous, and it's worth it if the patient is symptomatic and limited by it. But this is why I sort of, when I see these patients with asymptomatic varicose veins that look like the picture on the slide, I tell them, you know, there's probably some practice somewhere that you can find that would treat these on a cosmetic basis with foam sclerotherapy. I'm not going to do it, and I personally wouldn't advise that you get it done.
Great. It's really helpful. Thanks. Before we sign off, we just want to remind folks about Dr. Friedman and Wednesday morning, 8:30 grand rounds. That is an excellent series that you can also zoom in and eat your breakfast and put your Wordle down and check out his grand rounds. I think next week is radiation oncology. Last 2 weeks, we've had terrific talks by the chief residents, including yesterday's talk on fatty liver. We hope everyone will have a great weekend. Opening day at Fenway tomorrow. Hopefully you'll be there with 28,000 of your closest friends. And we won't see everyone next week. We're on vacation, but we'll be back the following week with Dr. Glitzman and sinus issues. So thanks again. Thanks, Petya, and thanks, Abe, for coming out and talking to us about venous disease. Bye.
Thanks, Petya, and thanks, everyone.